So first of all, I would just like to say a huge thank you to the Beat SCAD trustees for inviting me today. I am truly honoured and humbled to be here, and I am in awe of the amazing work you do to raise the profile of SCAD and the fantastic partnership working that you've fostered. So thank you very much. It's a privilege. So I am going to talk today a little bit about FMD. So I'm a kidney doctor, I'm not a heart doctor, but I've definitely had to learn to become a whole system doctor as a result of my interest in FMD. So I'm going to explain the talk title as we go along. So I've been asked to cover these 4 areas today. I've been asked to talk about what SCAD patients need to know about FMD, the impact of the latest genetic research on FMD. I'll tell you a bit about our dedicated FMD clinic, and then the UK FMD study. So I'm also today wearing my zebra print in solidarity with a rare disease, and we've also worked with medics for rare disease before, who are a fantastic group of raising awareness among doctors. So I am mindful that most people in this room are very well read, so I've decided to make my talk today a little bit more data heavy, a bit more science heavy as compared to my previous talks, but of course I'll break it down as we go along. So you'll be mindful that there's this very long definition of FMD, but let's break it down. So the definition of FMD has not changed, it has remained the same. So it is idiopathic, that means we don't know the cause. It is segmental, that means that it affects parts of the artery. It is non-inflammatory, so in other words, there's no inflammation or infection seen inside these blood vessels, and non-atherosclerotic, so there's no furring, buildup of fats, cholesterol in the blood vessels. To diagnose FMD, you have to have the presence of stenosis, so a narrowing, okay? So the picture on the right, I'm going to talk a bit about hose pipe. So imagine just sort of like a straight hose pipe, which is what a usual kidney artery might look like, whereas somebody with FMD is going to have some narrowing in it. In this particular case, we've got this very beaded appearance. This particular patient was somebody who came forward to be a kidney donor, so didn't know that they had FMD before, and this was picked up after he came to our clinic. So what else do we know about FMD? We know that it most commonly affects the kidney arteries. The second most common site that it affects is the neck or the carotid arteries, but it has been described in almost any arterial bed in the body. And it is possibly thought to be present in between 3 to 6% of the population. This is according to data from people who've come forward as kidney donors and then incidentally found to have FMD, as well as people screened for a research trial in America called the Coronary study. But how do we diagnose FMD? So unfortunately, we don't have a troponin blood test or anything like that. The way we diagnose FMD is on imaging. So you need to have an MR angiogram, not an MR scan, CT angiogram, or intraarterial angiography. These are how you diagnose FMD. The majority of patients will have the multifocal type. So that's your string of beads seen on the left here. And this is the type that's seen in patients with SCAD. Less often you find the unifocal type, so that's where you've got a slightly more focal or narrowing stenosis. This one is more common in children, more common in men, more likely to present with symptoms that are due to lack of blood flow to that area. But the more we're imaging patients, the more we're seeing that there are multiple other features in blood vessels. So we're seeing a lot of loopy blood vessels, we're seeing a lot of like S-shaped curves, aneurysm, so that's where part of your artery is a bit ballooned, a little bit expanded, and so lots of other features that we're noticing in the imaging. This doesn't mean that it's significant, it's just something that we're noticing, that some of the blood vessels look a little different. And what are the risk factors for FMD? So this picture very much shows you the faces of FMD. So it's 9 times more common in women, just as SCAD is. And just again as in SCAD, 80 to 90% are young to middle-aged women. Men are more likely to have these bruises, as Dave called them, the tears in the blood vessels, dissections. But we do see that people who are either smokers now or have previously been smokers are more likely to present with an event in FMD. And of course, there's the link with SCAD. So how can FMD present? And in the vast majority of people, it is asymptomatic. There are no symptoms. But you can get the minority, the small group, with more pronounced symptoms. And that's where you might get anything linked to bruising, tears in the blood vessels, swellings that might burst, blood clots, lack of blood flow. I do emphasize this sounds very dramatic when you say it, but this is genuinely the minority who are going to present with such symptoms. And of course, it depends which part of the body has been affected. It's more common to pick up the more chronic effects, which we see in clinic. So around 70% of the FMD patients will have high blood pressure, high rates of headache as well, 57%. Around a third are described as having pulsatile tinnitus. My experience of this is actually a little bit higher. Neck pain. You can pick up this, what we call a bruit in medical terms. It's where you get turbulent flow in a blood vessel that we can hear over the neck artery or the abdomen. Some can get flank abdominal pain. And then if you've had any tearing of the blood vessels of the neck, you can also have something called a Horner's syndrome, where you have a slightly droopy eyelid, smaller pupil. But that's enough about sort of FMD on its own. Let's talk about FMD and SCAD, because that's what I've been asked to talk about. So there is a lot of overlap. It disproportionately affects women, as we've said. It's mostly in middle-aged women, often a delayed or under-recognized diagnosis. And we see that in less than 5%, there might be something that's running in families. So again, this is something that needs to be explored a bit more. The more that time goes on and the more we get longer data in registries, the more this number actually drops. So less than 2% is currently what the European registry is showing us. Data says that up to 86% of SCAD patients can have an associated FMD. In my next slide, I'm going to just talk a little bit more about, do we think it's really that high? But the reverse isn't so much the case. So less than 5% of people who've got FMD will have a subsequent SCAD. That's, of course, assuming that it's been properly diagnosed, because one study found that they didn't classify if you would regard as having a heart event or a heart attack that wasn't formally diagnosed as a SCAD. So it could be a little higher, but it's certainly not common for FMD patients to have a subsequent SCAD. The question is it really as high as 86% of SCAD patients might have FMD? And this particular paper, of which Dave was principal investigator, what I call it, the main author at the end. So in this particular paper, there were 173 patients with SCAD. And the beauty of this paper is that very rigorous, standardized methodology was used to diagnose FMD, because we often find that FMD can be overcalled or undercalled depending on the imaging. So this was very much looking at gold standard methodology. And what they found was that there was a lower detection of FMD and a lower detection of other vessels being involved. So 8% having aneurysms, 2% having dissections. And these findings are in keeping with a large Canadian cohort. So 750 patients also had similar lower levels of FMD. So even though there were lower levels of FMD, again, migraines reported quite highly. And interestingly, the prevalence of this loopy vessels arterial tortuosity wasn't particularly different between whether you had SCAD and FMD or not. And what was also very good to see is that there were no FMD vascular events after 5 years of follow-up. So I think that just emphasizes that just because you've got FMD as well as your SCAD, it doesn't mean that the FMD is going to be more aggressive. And the next paper very much talks about the same thing. So this is from the DISCO study. So this is a European group. And in this group of SCAD patients, 45% had FMD. Those with FMD were likely to be a little bit older, a bit more likely to have blood pressure, a bit more likely to be postmenopausal. But importantly, having SCAD and FMD did not mean you had a more severe clinical presentation. Your imaging data was different, the management was different, the likelihood of a recurrence was any different. So I was asked to talk a little bit about genetics. So we do know that recent genetic work is actually quite exciting in that there are some variations within certain genes which may pose a risk towards a vascular event. But these gene variants can be reasonably common in the general population, and we don't necessarily know that they are very effective. They might only exert a moderate effect, for example. And importantly, it's not just about a gene that might cause an effect. What about the checks and the balances? Because it might actually be those checks and balancing genes that are playing a role here as well. So there's still a lot we need to learn. A lot to understand the mechanisms, the relevance, and there's also quite marked differences in how often these variants are found in different populations, different ethnic groups. So again, a lot to understand, but it's a promising start. Within a particular factor gene, there is a variant within the gene that if it's got the A variant to it, this puts you at slightly more risk of having a SCAD. And lots of research papers will have this thing called OR, which is called odds ratio. That just sort of helps you to understand how much more likely you are to have an episode. And if you've got this particular variant, then you're 60% potentially more likely to have a SCAD. So whether you've got SCAD with FMD or without FMD, there's still a raised odds ratio. So this is leading us to think that SCAD and FMD might be on the same spectrum, but different ways of manifesting from a single disease entity. Having this gene variant isn't going to necessarily predict the age the event might happen, pregnancy, SCAD, or any recurrence. But why is this gene of interest? So I took this from Twitter because I thought it quite nicely explained that you do need some equilibrium in any genes that aren't quite working as they're supposed to. So this particular gene variant puts you at slightly higher risk, possibly, of not just SCAD, but of FMD that we've mentioned, but also of migraines, also of cervical artery dissection. So that's in the neck artery dissection. High blood pressure. But whereas on the one hand it might make you a bit more prone to these events, it actually reduces the risk of having coronary artery disease. So that's your traditional atherosclerosis, FEIRI, etc. So again, we need to understand a bit more about equilibrium. So you need equilibrium for optimal vascular health. So in which too much narrowing of something that controls the narrowing of the blood vessels can make you more prone to atherosclerosis, whereas too much vasodilation, in other words, that means it makes it a bit larger, a bit more ballooned, can make you prone to aneurysms, dissections. So this is very much in the research realm. I have to emphasize that because I suppose the next question is, well, why aren't we all being tested for this? Because there's a lot to understand before you implicate a gene in any particular condition. So it's a start. But the next question is, well, are there any genes that are potentially useful in clinical practice? And there is one for FMD. This is, again, very new work, and it's only in a very tiny subset of FMD patients that it might be positive. So it's to do with collagen. So collagen, you might have heard of, plays an essential role in the structure and the function of skin, cartilage, bones, blood vessels, connective tissue. So you might have heard of some collagen disorders. So some of the more common names are things like Ehlers-Danlos syndrome, rheumatoid arthritis, lupus, ankylosing spondylitis. So these are conditions in which these collagen anomalies are noted. So what they've found is that a very novel but very rare variant in something called collagen 5A1 can be associated with a more aggressive type of FMD. It's a very particular type of FMD that makes you a bit more prone to dissections, tears in the external iliac artery, so the ones in the legs, the celiac artery that's within the abdomen, and carotid artery lupiness, if I can put it that way. So we can request this test in people who've got a slightly more aggressive type of FMD. So although I have requested it a few times, none of it has come back positive, but it's still a start. We've got to try to put all these little pieces of the puzzle together. I suppose the question is, well, why bother doing a genetic test if we don't know enough about this just yet? But I would say that if you have got this positive blood test, then it just means that we will be surveying you a little bit more often. We'll be doing imaging tests more often. We'll be super strict with your blood pressure, advise avoidance of contact sports, advise surgical precaution if you're having any operations on blood vessels. So we are starting to spot genetic trends, and we're starting to spot that there is overlap between a number of conditions, so SCAD, FMD, migraines, cervical artery dissections. But just having a genetic susceptibility is not enough. So what turns this gene on? What sort of sparks the series of events that might lead to a subsequent SCAD or FMD? And this is where there is a dearth of information. We do not know. There's lots of theories being put forward and a few things being tested. So one question is there something to do with mechanical stretch of the artery? So your carotid arteries, your kidney arteries are in locations of quite a bit of stretch with movement, positional change. So is it possible that vascular injury that results from all this movement might promote these smooth muscle cells inside to become scarred and fibrosed? Hormone changes, again, is obviously a hot topic. Are there some hormonal changes that might then predispose to vascular events? So there is a lot to sort of understand still about what is this interlink between possible genetics, possible other lifestyle and other factors. So many, many questions remain, and we have got lots of pieces of the puzzle that we're still trying to actively put together. But I suppose the question is, well, how are we going to try and put all these pieces of the puzzle together? And nothing quite gets attention like a front page headline in the Wall Street Journal. So this was from 2009, and following from the Coral trial that showed a couple of patients who came forward to be screened for this trial to do with renal vascular disease. They were incidentally found to have FMD. So this went on the front page that often diagnosed FMD can affect up to 5% of Americans. But it certainly does help to raise awareness. And what I do want to emphasize is that this is the power of patients, because the FMD Society of America are truly inspirational. They have driven all the research in America, they have funded research, and they have helped to set up the US Registry for FMD. So that's been going for about 15 years now. There are 3,000 patients enrolled to that, and lots of very interesting publications. So they were the first to find that FMD can be in multiple vessels of the body, so around 2/3 of people don't just have kidney arteries affected. So very, very exciting. There is a very dynamic patient group and amazing work coming from the States. Let's talk about the FEIRI godmother. That was the title of my talk. So similar to in America, in Europe, we have the European and International Fibromuscular Dysplasia Registry. That started in December 2015, and as of now, they've got 1,800 patients pooled from 22 countries. So it does emphasize it is a rare condition. We do, between us all as clinicians, might have a few patients, but if we pool resources, we can make this data count a bit more. And again, some really interesting and insightful information coming from these registries. So the data from the first 1,000 FEIRI patients, very similar to things I've already mentioned today, in that more common in females, more common in Caucasians, but lower levels of atherosclerosis. So again, that's, links a little bit to the gene studies that we've seen. And it also puts some predictors of who might be more prone to having tears in the blood vessels, etc. But the wonderful thing about FEIRI is that it is a masterclass in collaboration. And I've put a photo of Professor Alexandre Persu at the bottom, because he really is a tour de force. He's the most wonderfully collaborative person who really has the patient's interests at heart and tries to collaborate with anybody who's got an interest in this area. And some really insightful papers have come from FEIRI collaboration. For example, this is the first international consensus paper on how we diagnose and manage FMD. There's only one paper to remember from today. This is the paper. So this basically pulls all expert opinions on how do we manage and go forward with FMD. This is also another interesting paper that's come from the FEIRI work, and that looked at pregnancy-related complications. So they looked at 524 pregnancies in 237 patients. And what was interesting is that 96% of patients only had FMD diagnosed after pregnancy. So they didn't know that FMD at the time of pregnancy. And when they looked back, there were higher rates of having high blood pressure, but luckily there weren't significant pregnancy complications noted. So whilst there was a 7.5% preeclampsia, this was not particularly different to the general population. Preterm delivery only ever so slightly higher than the general population. So the moral of the story of this paper was to screen young women who develop high blood pressure during pregnancy. There should be sort of a higher index of suspicion that potentially this might be FMD. They did find that patients who had any pregnancy-related issues such as high blood pressure, etc., were younger when the FMD diagnosis was picked up, and they were more likely to have kidney FMD, so renal artery FMD. And again, why pick this up? Because if you have got renal artery FMD, there's an opportunity to do something called angioplasty. So that's when you open up the narrowing of the kidney artery, and then you're much less likely to have problems during pregnancy. So the bottom line of this paper was, do not discourage patients with FMD to fall pregnant. Again, this is very, very new, but I still thought it was interesting and cutting edge, so I'm going to mention it. So again, a very dynamic group in the States are looking at, can we maybe develop a blood test for FMD? So this is very much in its infancy. But again, by studying populations with FMD, they've looked at whether there's a signature from the proteins and the lipids in the blood, and they have found in the discovery group something called a CD2-associated protein that was more noticeable in people with FMD. And then they looked at this in another group to see, can we validate this test? And they did find that when they looked in this other group that didn't have it in the discovery group, if that makes sense, about the sensitivity of this test in detecting FMD was about 78%. So this is exciting in that it's possible in future we might be able to develop a blood-based test. So this is very much in the research realm, but I thought I would just mention it just to sort of give hope that there is a lot of exciting development slowly coming together. Everything I've mentioned so far has been in America, has been in Europe, and nothing from the UK. So research on FMD has lagged behind in the UK. But we have been so inspired by the success and the impact of FEIRI, the American initiatives, the Beat SCAD group, and so we also wanted to join the frame. We very much wanted patients at the heart of the involvement of this work. But how? And I won't go through all the very difficult trials and tribulations of trying to get something up and running, but instead of going for like the quick win of just doing one centre, we've opted to go for national collaboration, so to try and get a national UK FMD study. So this sort of came out of the UK and Ireland's first patient information day that we held at Salford Royal. And Karen, you were there. I think you were there as well, Bex. You were there as well, weren't you, Sarah? So thank you. It was so wonderful just to have such a great patient group presence, because one of the goals of the day was not just to give information to patients, but very much to get a wish list at the end. So at the end of the day, the patients got together and they gave us their clinical wish list and their research wish list. So the number one thing that you asked for was a dedicated FMD clinic. So because again you might have FMD in different parts of the body, it was quite tricky to coordinate your care, different people with different levels of expertise. So there was this real need for having a specialist dedicated clinic. An acknowledgement and validation of the condition, because it is often symptomatic. People don't know anything about it necessarily, so a lot of GPs don't know anything about it. So just important to have that sort of like brand to the condition. And then research, there was a big appetite to also form a registry. So we'll talk about the first point. So the first point was setting up an FMD clinic. So at Salford Royal Hospital, we set up a bespoke FMD clinic in February 2020. So this clinic benefits not just from renal input, but we have neurology input, we have neuroradiology input, we've got interventional radiology input, and we do MDTs to discuss the patients. So up until now, I've had 120 patients come through the clinic, and partly because of COVID, we converted to telephone consultations, but that also opened the door for us accepting patients from all across the country. So actually 62 of my patients have come from out of our Salford region catchment area. The one thing which I did not expect was how many patients turn out to not have FMD. So actually, Dave and I were talking about this earlier, but FMD can either be overcalled or undercalled sometimes on scans. And I've had to really educate myself about a lot of other conditions which are FMD mimics. So for example, I've had patients come to me with inflammatory conditions called Takayasu's, segmental arterial mediolysis, neurofibromatosis, vascular Ehlers-Danlos. So I've really had to sort of educate myself about these conditions, and it just shows the beauty of an MDT that can properly look at your films. I would say at least a third of the patients who've come my way haven't had images that are good enough quality. So either the slice thickness is too thick and the images are blurry and then it overcalls it. One thing we do is make sure that the imaging you've had is high quality, that we can say definitively this is FMD, it fulfills the diagnosis. The data from the patients that have come to the clinic are very similar again to what we've seen presented. So mean age of diagnosis is around 42, obviously quite a variation. Majority female, 2/3 have got FMD in multiple vascular beds. With regards to SCAD, so I only have a few patients with SCAD in the clinic, but in all of those, the SCAD came first. So the SCAD came first, and then the FMD was actually in the majority incidentally detected. So in the majority, it hasn't caused any problems. There were 2 in whom they presented after having had a neurological event, but the majority it is not problematic FMD. I've only had 1 that had FMD first, and that was from 2003, and they presented with a SCAD in 2018. Then I've had a couple with SCAD who've not been found to have FMD. So what do we do in the clinic? So the first, most important thing is confirm the diagnosis. Make sure you are dealing with FMD and not something else. We very much advise that you have this once-off sort of top-to-tail imaging. In our particular centre, we have to do it in 2 settings. Our neurologists prefer MR angiograms for the neck up. We prefer CT angiograms with high-resolution slices, sort of neck down. We advise to stop smoking because of the data showing that people who are smokers might have a slightly more aggressive FMD course. We talk again, it's a very individual discussion, that are you somebody who might benefit from antiplatelets, yes or no? We talk a lot about blood pressure control. We do get quite strict with making sure your blood pressure is well controlled. But one thing that is quite unique to patients with FMD is if you have got a kidney artery FMD, there are a group of patients in whom angioplasty, so that's where you put a balloon into the artery and you open up the narrowing, is hugely successful. So we have a number of patients in whom the blood pressure is cured, or in whom it's improved so much that they can reduce their medication tablets. So we do need to look out for those people in whom this is an opportunity to improve their blood pressure. Again, FMD doesn't tend to have stents going in. There's only a very tiny group of people in whom they need stents, but the majority should not have a stent put in. But we do focus on multi-specialty management because FMD can affect so many different parts of the body. Patient education is very important because often people will come to us with lots of different symptoms, and it doesn't necessarily mean that they're all linked to FMD. So in particular, people who are migraine sufferers, headache, various neurological conditions, it's really helpful to actually physically see our neurologist because she can help to discern what is FMD and what isn't. I would very much advocate for avoiding neck manipulations. I have had a good few patients present with a carotid artery dissection, vertebral artery dissection after having had neck manipulations. If I can just copy and paste exactly what Dave said about oral contraceptive pill, hormone replacement therapy, pregnancy, that's copy and paste. We very much give the same advice. It's a very individual discussion. And we signpost to the UK FMD group, which Karen is our champion of. Fantastic to have the sense of community and the sense that I'm not alone going through what I'm going through. And of course, we want to signpost now to research. So let's get on to research and then I'll start tying up the discussion. So originally we thought we could start a UK FMD registry by going through RaDaR. So RaDaR is the Renal Rare Disease Registry. But we soon found that actually the data that you can collect by being part of RaDaR is extremely limited and isn't valuable for any of the questions that we want to ask. So after much discussion, we have decided to join FEIRI. So we are now regarded as the UK arm of FEIRI. Now, the beauty in that is that we can upload directly onto the portal. We are collecting the same data, so we can compare data. It allows for more generalizability of data and validation. So Salford Royal is the sponsor site, and we're in the process of onboarding different hospitals as we go along. The only slight challenge is that the UK FMD study is not portfolio funded. Now that will mean something a bit more to the clinicians in the room. If you're portfolio funded, it means that you immediately gain funding support from our NIHR to support your nurses' time to upload into the database. So we don't have that, but you can recruit patients to both RaDaR and the UK FMD study at the same time because RaDaR is portfolio funded. So we're trying to sort of piggyback a little bit on that at the moment. So the UK FMD study includes children. As I've said, there's more than 50 data points. Collecting blood and DNA tests is optional. And we also can include SCAD and FMD as well as FMD. And we also have a group called atypical FMD. If you haven't got the stenosis, but you've got some other anomalies in the blood vessels that look a bit similar. So is the UK FMD study coming to a centre near you? Hopefully yes. So those in yellow are those who are either onboarded or in the final steps of onboarding, and all the other centres are on their way to joining the FMD study. But it is still regarded as a rare condition. We have to pull resources, so hopefully we can all onboard because every centre will have a couple of patients that will ultimately accumulate to a large number of patients. I'm going to finish there by saying thank you, Beat SCAD, and thank you to everybody who is here and supporting, because research in SCAD is helping understanding of FMD and vice versa. There are so many parallel lessons that we're picking up. If you've had a SCAD, I would advise this head-to-tail imaging to look if you've got any FMD, but it doesn't necessarily mean it's more aggressive FMD or more aggressive SCAD if you've got it. There is no genetic or blood test just yet. We're relying on imaging. But I accept referrals from all across the country, so you're very welcome to be referred to the FMD clinic, and please join the UK FMD study. Thank you.
Thank you. I'm just going to look at the boss. Have we got time for any... does anyone have any questions for Tina at the moment? Have we got time just to take a question? Yeah.
It's a quick question. Just thank you so much. I think I did have the test and said that I didn't have this, but is it something that you either have or don't have, or can you develop it? Yeah, basically that's it.
Yeah. So unless we do serial imaging in people, we don't know for sure. The majority of people we don't think are going to develop FMD. It looks though you might have the changes already at the time of the SCAD. So I would say that that applies to the majority of people, yes.
Thank you very much. Yeah.